My name is Shantae. I am the president and CEO of Black Wellness and Prosperity Center. Yay! Our mission is to support the health and well-being of our Black mothers and babies. Yes, that deserves a clap. And what we know by doing that actually improves outcomes for all of our populations and all of our communities. So first, I want to thank our sponsors, and we're going to be really efficient with our time because there's a lot of exciting stuff to get through. So I want to thank our sponsors, Anthem. On your way out, you will receive a beautiful blue bag from our sponsor, Anthem. There's so much that you can do with that bag. It's really huge. You can use it for groceries, laundry, whatever you want to use it for. But you'll receive that on your way out. Also, Calviva. I also want to thank our media sponsor, KVPR. And I also want to thank the Central Valley Community Foundation, specifically Elise and Julie, who you met coming in when you checked in. They have been supporting and helping us. So we really want to say thank you to Elise and Julie. And also, we want to say thank you to Bob Burrow, who's been an amazing host for Dr. Sharon Malone. I also want to thank my team, and I'm going to put you guys on the spot. I want you to stand up. Go ahead, stand up. Yay! For all of the amazing work that you guys do. So it's a team effort. Without you, none of this would happen. Also, there's something sort of exciting. So if you look on your chairs, some of you have stickers. And if you have a sticker, it means that after our talk with Dr. Sharon, we're going to invite you to go into the area where you registered, and you will receive a free copy of, yes, woo! And you will receive a free copy of Dr. Sharon's book, which she will sign for you tonight. Woohoo! Yes! Okay, so as also a nonprofit, I want to say that, we're really happy to support so many books for the community. And if you didn't receive a sticker, I'm really sorry. But there's a QR code for you to scan, and you can purchase the book. And what we do have for you, I just learned this phrase, there's something called a signature plate where Dr. Sharon Malone has pre-signed. And when you get your book, you put the signature plate into the book. Okay, so if you didn't get a sticker, again, I'm sorry. But purchase the book, and you can take your signature plate today and then place it in your book when you receive it. Okay, so there's a lot of exciting things that we're going to talk about, and I'm sure that you noticed, for example, that you have these really fancy kits on your chairs. These are Dr. Sharon's. Allison in the back. What's the full name of the kit, please? Louder. That's right. And it's really holistic. So we want you to enjoy this kit. It's really fancy. Excuse me. So just really quickly, here's how it's going to work. Oh, also I want to announce that on Saturday, we have a community event that we would like for you to attend if you're not already registered, or for those that maybe you support. It's Fall for Health. It's going to be held at Saints Rest. And where's Marcia? Marcy, there you are. time to what time? Sharp. Okay, at Saints Rest. And so we do have a resource table that is set up, and you can get information on your way out about that community event. Also on that table there are some information flyers about a 7-year research project that we are doing in partnership with Stanford around anemia. Did you all know that a lot of women of color experience anemia during pregnancy, and this is one of the areas that can be addressed to prevent preterm birth? It's really simple. So we're really excited about this approach, this partnership that we have with Stanford to try and figure out how to simplify and streamline this education topic. So again, if you're interested, there's a table in the back where you can get information. So I'm going to tell you a little bit about Dr. Malone. I mean, she's amazing. I can't believe that she's here in Fresno. Yes, I'm so excited. And then we'll have a Q&A. Orlando, raise your hand, please. Orlando is right here. So we want this to be really comfortable, very interactive. We have some questions that we're going to chat with Dr. Malone about, but then we want to take your questions. So we're going to invite you up to the microphone, right where Orlando's hand is raised. And so if you have a question, we will invite you to the microphone to ask your question. And then following our chat, it's called a fireside chat, but we don't have a fire. Just think of the lights, okay, as the fire. We have to think of our environmental health. No fires. So we'll have our chat, we'll have Q&A, and then we'll have the book signing. And then Dr. Malone is going to go back to Washington, but she promised that she's going to come back. Okay. So let me introduce Dr. Sharon Malone. Dr. Sharon Malone is on a mission to empower women to take charge of their health. I don't know how good that sounds. That sounds really good to me. Can I get some snaps, please? Okay. So Dr. Malone is a Washington, D.C. based OBGYN and a certified menopause practitioner. As Chief Medical Advisor for the digital health platform, Alloy Women's Health, Dr. Malone brings decades of clinical and real-life experiences to her treatment of women in the menopausal transition and the post-reproductive years. Before joining Alloy, Dr. Malone was a partner at the renowned Fox Hill OBGYN medical practice in Washington. She's board certified by the American College of Obstetricians and Gynecologists and certified by the North American Menopause Society as a certified national menopause practitioner. Dr. Malone has also served as an associate clinical professor of obstetrics and gynecology at the George Washington University and presented the 2012 PBS documentary Slavery by Another Name, which charts the violent transition in 1865 from chattel slavery to forced prison labor. Throughout her professional career, she has been active in advocating for reproductive rights, reducing teen pregnancy. I need some snaps, please. That's really quiet. Reducing teen pregnancy and eliminating healthcare disparities. During World War II, her parents, both of whom were raised in the rural South, moved to Mobile, Alabama, as part of the migration from farms to cities. She was born in Mobile, Alabama, to a domestic servant and a maintenance worker for Brooklyn Air Force Base, and she's the youngest of 8 children. She is also the sister of Vivian Malone Jones, who in 1963 became one of the first African American students to enroll at the University of Alabama in Tuscaloosa. She has seen healthcare from both sides, as a physician and as a child of parents who negotiated healthcare for themselves and their families in the Jim Crow South. Despite living next to two hospitals, preventative health care was never a part of her family's life. And as a result, Dr. Malone's mother would lose her life to colon cancer, diagnosed too late for treatment. Dr. Malone was 12 years old when she lost her mother. Dr. Malone was raised by her siblings after the death of her mother and moved multiple times, changing schools 4 times in 4 years in 3 different states. This life experience has informed how Dr. Malone has chosen to practice medicine and brought focus to the healthcare issues that she has chosen to pursue. Dr. Malone found strength and resilience in community, in her own work ethic, and in her strong belief that there's no accidents in the universe. She went on to graduate cum laude from Harvard. Could I get a what? With a degree in psychology and social relations. Upon graduation, she pursued a career as a systems engineer with the IBM Corporation. She didn't like it so much. She decided she wanted to go to medical school. So she went to medical school, and she attended medical school at Columbia University's College of Physicians and Surgeons, where she earned her MD with honors. Upon completing her residency at the George Washington University, Dr. Malone served women across Washington in her almost 30 years as a practicing OBGYN. In 2024, and I'd like to mention, originally we thought we'd have Dr. Malone here in October, but apparently she decided to win the Forbes 50 over 50 award. And that award ceremony was on the same day that we had originally planned to host her. So she was recognized as a Forbes 50 over 50 superstar for her innovative work in women's health. Dr. Sharon has appeared on the Michelle Obama podcast, Oprah Winfrey's The Life You Want, the CBS Morning Show with Gayle King, that's Oprah's bestie, and the Tamara Hall Show. Dr. Malone is a New York Times best-selling author and believes that all women should be able to make decisions regarding their health and their quality of life based on facts, not fear. Currently, Dr. Malone is featured in the M Factor, a documentary about menopause, and you can find that on PBS. Here's what First Lady Michelle Obama has to say. Notice I didn't say former First Lady. She is my First Lady. Quote, Dr. Sharon Malone is an OBGYN in Washington, and she's been such a wonderful resource, a steadying force in our group of women friends. So often, women have a lot of questions about our bodies, what we know, what we don't know, especially when we're going through a transition like puberty or menopause or anything else. Sharon has been such a godsend for us as we navigate these topics in our own lives, end quote. In addition to her interest in women's health, Dr. Malone is an avid reader, an amateur genealogist, and a lover of music. As a matter of fact, that music that you all heard during the cocktail social hour is her personal playlist, which you can find in her book. Finally, Eric Holder, the first African American Attorney General of the United States, is married to Dr. Sharon. They are the parents of Maya, Brooke, and Eric III. I would love to now welcome to the stage Dr. Sharon Malone. Also, we did not coordinate our suits.
Thank you so much. This is my first trip to Fresno, and I have to say it will not be my last. Everyone has been so incredibly kind and gracious to me, so I thank you so much for coming out tonight.
Thank you. We are so happy to have you. So let's get right into it. What is perimenopause?
Yeah,
I never heard that word or that term.
Yeah, perimenopause is, what is confusing about it is because it does not have a bright beginning, or it has an end, but you don't know when it starts. And I think for most women, and I'm just going to ask, a show of hands, how many of you talk to your mothers about menopause? Did your mother have a conversation with you? Okay, maybe about a quarter.
10%, a quarter.
Maybe a quarter of you did. But most of us don't have that conversation. And can you imagine entering puberty? And there are some generations who also entered puberty and didn't know what was going on.
And it was a surprise.
But, there are just as many changes that are going on in your body in perimenopause as when you go through puberty. And because so many of us are caught unaware, we don't even know what it is. And the unfortunate thing is that a lot of doctors don't know what it is either. And so the things that we normally associate with menopause, and I'm going to define menopause for you first and work our way back. Menopause is the age at which a woman has had her last menstrual period. Now, you don't know when you've had your last one until you look back and you realize, oh, I haven't had another one. But it's confirmed after 12 months of no period. Average age for that is about 51. Well, what is perimenopause? Perimenopause is that phase of life that you go through. It's also called the menopausal transition, where you are transitioning from your peak reproductive years, which are usually about your early to mid-30s, and menopause, the average age of which is 51. Well, that's a long time in between. And you're still getting your periods, but what's confusing is that you're also having a lot of the symptoms that go along with menopause. So the things that we think about, like hot flashes and mood swings and night sweats and sleeplessness and depression and anxiety and weight gain. Have I depressed you enough yet? But
I'm hot.
But all of those things can happen in perimenopause while you're still having your periods. And it is not uncommon when women go to see their doctor and they start complaining of these things, and your doctor goes, well, when was your last period? Oh, well, then it's not menopause. Yes, it is. You are in the menopausal transition. And I think that we have to recognize that is something that happens. It can last anywhere from 4 to 10 years before you get to your final period. So for a lot of women, I say the average age of having had your last period is 51. Who's average? No one. For black women, the average age of menopause really comes about a year earlier, which means that women can start having symptoms of perimenopause or the menopausal transition in their mid to late 30s. And
can you say that again, please?
In their mid to late 30s. And let me say, and the reason why that's important is because I think in our minds, we think that menopause is something that happens to old ladies.
Right.
And it's not. It's something that happens to young women, usually in the peak of their reproductive years. It has profound implications because many of us are having children later in life. And you just need to know and be aware of that and plan accordingly. And, I think that once we know that, I think that the things that start to happen to you aren't as distressing as they are. And particularly when you experience these things and you go to your doctor and your doctor is saying, I don't know. It's not that. And I'm here to tell you, yes, it is.
So What should women do who maybe suspect that they're, experiencing signs and symptoms of perimenopause, and they go to their physician?
Right.
And how do they have that conversation? How do they advocate for themselves and for their bodies
Right.
and what they're experiencing?
In an ideal world, your doctor should have had this conversation with you before you got to this point. That is what I used to do, because when my patients, and let me just say this, I had the luxury of being in one practice for almost 30 years. So I had women that I had known since high school and college and childbirth, and watched them right, through perimenopause and menopause. And so we had many conversations about it. It's not a one and done. It's a, let me tell you what's coming. Okay, now you're going through it. And then the next part of the conversation is, now what are we going to do about it? And whether or not to do anything about it or to actually intervene really depends on how distressing these symptoms are to you. And that is where I say every woman has a line drawn in the sand between what's tolerable and what's intolerable. And I don't know as a physician when you have reached that point, but my advice has always been whenever symptoms you are having are getting in the way with the quality of your life, your ability to do your work, or the ability to function interpersonally, then that's a problem and it needs to be addressed. And I don't think it's actually productive for someone to tell you, oh no, dear, that's just comes with being a woman. Just endure it. That's unacceptable.
Thank you. Thank you. So there's in healthcare, it feels like there's so many acronyms. It's like, what does all this mean? What is HRT? And why is there so much controversy or confusion around this?
Right.
And how do we approach it depending on your age and your risk factors?
I'm going to answer that question, but I want to back up a little bit, because I think it's really important that you understand sort of why I wrote this book. And menopause and perimenopause are chapters in my book, but it's not the sum total of really why I wrote the book. I have been a doctor to my patients, but I have also been a doctor for my friends and my family. My friends and family who are smart people, who have great insurance, who are capable of understanding whatever it is that someone would talk to them about. And what became clear to me was that there were a lot of conversations not being had, not just about perimenopause and menopause, but just about women's health generally. And I don't know if any of you remember that book or had that book, What to Expect When You're Expecting.
Yes.
Yeah. Well, my book is What to Expect If You Expect to Live Beyond 40. And that is my book. So it really addresses a lot of things, because I think that the one thing that is confusing for not just women, but patients in general, is to understand how much medicine has changed. In the 30 years that I've practiced, it was a totally different ball game 30 years ago than what it is now. The likelihood that you will have one doctor that you will see for 30 years is becoming a pipe dream. So if you had that, good for you. But for you young people, that's not going to be the lived experience. So what I wanted to do is to think about all the things that would be important for you to know how to advocate for yourself in an environment when you're having to constantly deal with someone that doesn't know you. Because it's one thing if you say, yeah, you know me, you know my family, but that's not the real world. We're going to change jobs. Your employer might drop your insurance, and then every few years you're having to re-explain yourself, your issues. I don't know whether or not you complain all the time or you never complain, because that sets in motion a different set of sort of activities that I'm going to do for you. So given the fact that there's someone who doesn't know you, you have got to learn how to be an advocate for yourself. And I start at the beginning, because I think, when I wrote the book, I thought about it this way. What are all the things that I wished my mother had had? What is the information that I wish that my sisters have had? And I'm the youngest of 8, and we are now down to 5. And none of my siblings, the ones who are no longer with us, none of them have lived to the average age expectancy. And I think a lot of that has to do with not just bad choices, it's not that. I think a lot of it has to do with not knowing how to access and when to advocate for yourself. Because, I talk about a sense that most of us have. You have it, but you didn't know what to call it. And that's the sense of interoception. And interoception is just the internal feeling of what you feel like when things feel normal. When you walk around every day and you're feeling good and nothing's bothering you, you're not thinking about, oh, my knee hurts or my head hurts. Interoception is that sense of normalcy. When something is not normal, that's your body giving you a signal. A headache might mean you're tired. It might mean a brain tumor. It probably doesn't. But my point is that your body's giving you signals all along. And you have to learn how to pay attention to them. And you need to know which ones are important and which ones are not so important, and which things you can self-minister for, because not everything you need to run to the doctor for, and that's why you've got your little kits, because
yes, thank you,
talk
Dr.
about
Malone.
that.
That's actually a perfect segue. So you mentioned something really important, which is healthcare is changing.
Oh,
It's not generational anymore. I can think of 2 examples actually in this room. I'm thinking of Dr. Ulysses Curry, for example, who is a generational provider. I'm thinking of Dr. Denard Fobbs, who's been a generational provider, but that's changing. So something that's really important that Dr. Sharon talks about, if you look on your chair in your handy dandy notebook, something that she really advocates for is knowing and understanding your family health history. And that is going to be something that will be helpful as you're transitioning between providers, between insurance plans, between life experiences. It's documented. It's in your family health history. So we provide a guide in your notebook of how to get started.
Right.
Thank you for that.
You are so welcome. But not only do you need to know your family history, you need to know your history. And you would be surprised how many times, and I see a doctor here in the office, that people show up in your office and you say, well, okay, well, I had a surgery. Well, what was it? I don't remember.
Yes.
You know, something was removed, or I'm on a medication. What medication is that? For
I don't
high
know.
blood pressure. You don't know what it is. You don't know what the dose is. You know, there's just certain basic things about your own health history you should know. It's important. It's important for whoever that person is who doesn't know you, who may not have prescribed that medication, to know not to prescribe something else that may counteract that. So first things first, don't assume that someone has got you. Assume that they don't. And the only person that, you know, that knows and can keep up with that on a regular basis is you, because I say no one cares about your health more than you do. And so you should act accordingly. And the things that, and once that's a good starting point, where are my medications? Make sure that when you walk into that office, that you leave with, one, you need to be prepared and you know what questions you need to answer, you know, you need to ask when you get there. And make sure those questions are answered. And if they're not, make a plan for how you are going to follow up to get those answers. It's not sufficient to say, well, I'll talk about it next year. No, you need to have a plan with how to follow up. And then when I talk about family history is incredibly important, but not for the reasons that you think it's important. Particularly when you talk about African Americans in this country, when I say, how many people have a family history of high blood pressure? Raise your hand. Family history. How many people have a family history of diabetes? How many people have a family history of diabetes and hypertension? All right. How many people have someone who has had a heart attack or a stroke or heart problems or dialysis? Keep your hands up. You see what I mean? That is so prevalent. But the reason why I want you to know that and know that family history, because I think that family histories tell you what you are predisposed to, not what you are going to have. And I think that the message that I give a lot is, genetics is not destiny. Genetic tells you what things to look out for. And I use the analogy of, if you are driving in your car and there's a sign up that says, bridge out ahead, do you put your foot on the gas and keep going? Hopefully not. At a minimum, you should slow down. But what I'd really like for you to do is say, hey, let's pump the brakes and turn this car around. And that's what most things in your family history are really about. And I think that we make the assumption that it's in my genes, it's inevitable. But families share a lot more than just their genes, our environments, our health, history, our interactions with medical physicians. I have a terrible family history for cancer, for early death. I had 7 siblings, and of my 7 siblings, 6 of them have had a total of 8 cancers. Now, is that in my genes? Hopefully not. But I think it's more to do with how we lived, about living in Mobile, Alabama, about the kinds of foods we ate, the stress that you're under, the racism, the lack of access to quality health care. All of that is important. And I would hazard to say more important than what's in your genes. So that I want you to keep in mind, because I want my book to be an empowering tool. Because no, we're not going to throw our hands up and say, oh, well, everybody in my family's on dialysis. Well, how about this? You be the first one who's not on dialysis. And there are things that you can do to make sure that you don't end up in that same fate. So that's why I said, I want you to know it. I want you to act on it. I want you to be able to share that information with families, because we're coming up on Thanksgiving. And Thanksgiving has been designated, everything's got a day or a month these days.
Yes.
Ooh, it's Rare Red Suit Day. See, we got the memo. But it's really, Thanksgiving is a time to really, while families are gathering, to talk about the things that you may or may not know, because a lot of times we don't know things. People will die, and you're like, well, I didn't know Aunt Bertha had breast cancer.
Nobody told me.
We're just finding out things. It's like, well, why didn't I know that? Because we don't discuss them. And we have to get out of that mode. We're not, cancer in my mother's time was something, people were embarrassed to even say the word out loud. It's like, oh, she's got cancer. And, you wouldn't say it. And cancers in my mother's generation were caught so late that it didn't even matter what kind it was, because most of the cancers were caught when they were already too late to do anything about it. And, and that spawns things that get in the way of our being able to access care. Like I grew up in the South, so you guys tell me if you've heard any of these things. Old people used to say, well, somebody's got cancer and they have surgery and it comes in and it's like, oh, it's metastatic cancer. And they would say things, well, she was fine till she had that surgery. Once the air hit it, it just took off. And you're like, I'm like, I don't think that's how it works, but okay. But those are the stories we tell ourselves.
Right.
As if somehow because the takeaway from that is, well, if she hadn't had the surgery, she'd be fine. And, and as prevention, as just a way of interacting with physicians, was never part of how we lived. My parents grew up in rural Alabama, so I want you to do a little bit of math here so you can understand the depth and breadth of my immediate family. I'm the youngest of 8. My oldest brother is 88. My mother was born in 1914. My dad was born in 1893. So how they lived in rural Alabama, when there were no doctors, it's segregation. You couldn't afford, you had to go then in those days, they had to get in a horse and buggy and go
Right.
fetch a doctor. And they were always fetching
Or a midwife.
Yeah, and it was too late. And it was often too late. And so, again, the conclusions that people drew were that doctors brought trouble. But they never thought about the notion about prevention. It wasn't a thing. I mean, come on. They grew up in a time before antibiotics and insulin. So, illness and death and disease were like bad weather. They were just like impossible to predict before radar, and nothing you could do about it other than endure it and hope you come out on the other side. So I say that to say that, we have got to change our relationships. We've got to shift the locus of and the focus of the power in that dynamic. Your doctor does not know everything, and if you don't tell them a good story, then they won't be able to help you effectively. And those are the kinds of things that I talk about.
Can you say
in the
that
book.
one more time?
Yes.
If you don't tell.
If you don't tell, or if you tell an inaccurate story. And I talk about this because, so much of medicine is about storytelling. It is about you being able to tell your story, and it is about a person being able to say, okay, I hear your story, I recognize that story, and together, hopefully, we will craft an ending that works for both of us, a good ending, not a bad ending. But if you show up, and as I said, you don't know what medications, you don't know what the dose is, you don't know how long you've been on it or what you're taking it for.
But they will now.
They will now. And those are the kinds of things. And these are simple things. These aren't complicated concepts. I don't need you to go to medical school. I don't need you to be a neuroscientist to figure this out. But so every chapter in my book is really designed to, and I called it Grown Woman Talk for a reason and not Menopause Women Talk for a reason, because the book is for every grown woman, whether you're 20-something, 30-something, 70-something, because the book really ends with how to get your house in order.
That's also
your
in your
metaphysical
notebook, by the
house in
way.
order. Because we don't talk about these things. And you'd be so much more at ease if you did, and you just took some very simple advice that's not complicated. Now, that is not even the question that she asked me.
No,
And
it's not.
I just want
but
you to know.
But I was going to segue. Thank you.
I just want you to know that I do remember the original question, because that's because that's one of the other signs of menopause. Like, what was I talking about? I do remember. I am, and we're gonna come back.
What is it? And I've been the timekeeper all day since this afternoon.
I told her. She said she had a list of questions. I'm like, oh girl, we will get to those. We're not getting to those. But we're going to talk about some things. We're going to have some grown woman talk. But it's for grown women of any age. And it is for men who know grown women or who care about grown women. Because a lot of the things that we talk about perimenopause and menopause, you men who are out there who know women, whether be they your spouse, your girlfriend, your sister, your mother, you need to have a little grace and understand what we are going through. And let me tell you, it's not easy.
Can you say that again?
All right, I'm gonna say it like we say it in Alabama. It ain't easy. It ain't easy. But and that's why I do spend time talking about that, and I am going to come back. But we talk about cardiovascular disease. We talk about chronic stress. We talk about hypertension. We talk about strokes. All the stuff you should know. And the basic things that you should do to prevent, whether you're preventing cancer or heart disease or strokes, it's all the same 5 basic things. And once you do that, that's exercise, eat a healthy diet, get a good night's sleep, don't smoke, cut down on alcohol. That's it. Right. And you're like, oh, that's all?
Dr. Malone, let me do this really quick. I want to be really explicit. So I really want to direct this conversation to partners in the room right now. So if you turn toward the back of the notebook, you'll see signs of a heart attack. So signs of a heart attack is very different for women versus for men. There's also information in the notebook about what a stroke looks like, and then also about fall prevention. The reason this is so important is because we're talking about perimenopause and menopause, but guess what? If I fall, and anyone in this room who knows me even a little bit knows that sometimes I fall, who's going to be with me? It's probably going to be my partner.
Yeah.
If I have a stroke or a heart attack, it's not going to happen to me. That's what it's not going to happen to me. But who is likely to be with me? My partner. Who is likely to be with you? It's your partner. So they need to understand what the signs are of a heart attack in women and a stroke, because you have so much time. So it is our partners who need to be aware. And what did you say about grace and understanding?
About what?
They need to understand.
Oh,
we're
yeah,
just
they have a
going
little
through
grace.
some things.
Yeah, it's hard out here for a woman. That's all I'm saying.
Okay, so
All right, so we're going to get back to the perimenopause
yes, Mother
and menopause
Desi has
question.
taught me about timekeeping, and I'm
Okay.
looking, and I got to tighten it up so we
Okay,
can
we're
get
tightening
to
it
Q&A.
up. I told her,
Okay.
I said, we're going to
yes,
get 3
we're
questions.
Okay, so we got to our partners.
Yes.
We got to signs and symptoms. Look it up. Read it.
And your question was about hormone
Hormone,
replacement
we
therapy.
got to talk about
Okay,
it. What
we're
is
gonna
it?
talk about hormones. Okay. Let me just tell you, we get back when we talked about just the general, parameters about what is perimenopause and what is menopause. And, the question of when to treat and when, who should be treated, who shouldn't be treated. Well, and I will spare you the details, but when I started in practice in the 1980s when I was in med school, we were taught a lot about menopause. Hormone therapy was a staple of what we prescribed for women because it worked. And hormone therapy isn't new. It had been around since 1942. Women have been complaining about the same signs and symptoms of menopause for as long as women have lived long enough to achieve menopause. So when we talk about hormones, something happened in 2002 which really changed the whole conversation about hormones. And that was a study called the Women's Health Initiative. And that is where the negative connotations that most of you have about hormone therapy, oh, it causes breast cancer, oh, it doesn't help with heart, it's harmful, it's dangerous, I'm going to stay away from it. Let me tell you what that's done in the 22 years since that study came out. It has amounted to untold suffering for women because hot flashes are not benign. Night sweats are not benign. These things are often harbingers of other long-term health implications of menopause, cardiovascular disease, high blood pressure. The sleeplessness that comes from menopause leads to, guess what, brain fog and irritability and depression the next day. And you know who suffers the most? Black women. What we do know from a study called the Study of Women Across the Nation that just followed women for 25 years. They didn't do anything. They just let's just see what happens. And they followed you from premenopause to menopause. And what they found is that how menopause is experienced differs by ethnicity. Now, is it because, again, we get back to the, nature-nurture situation? It's not because black women have different genes or somehow we have to go find out what the biologic basis is.
So we don't have thicker skin, is what you're saying?
No, you do not have thicker skin, and we do not have higher pain tolerances either.
Thank you.
But it is because the lived experience of being a black woman in America is different. You are under different stressors. You are more likely to enter menopause in poorer health, generally. And so these things that affect 80% of women will affect 90% of black women longer, more severely, and earlier. And the consequences of not treating that with hormone therapy leads to other more serious complications down the road. And if the people who need it the most are getting it the least, then that means you're also suffering the long-term health complications of menopause as well. Here's a little statistic that I did not know until I wrote this book. I also have a chapter in there on Alzheimer's. And the reason why that's is important is because I did not realize that Alzheimer's affects women twice. 2/3 of the people in this country with Alzheimer's are women. And it's not because we live longer. We don't live that much longer. It's because, and again, we're like, well, what is it? What is the difference and why does it start? It starts happening in the process after menopause. The other thing that came up, and again, we don't have really good data on it because I don't know why no one was curious as to why women have twice the risk of Alzheimer's in men, because it was like, it's one of those things where, ooh, that's just women, what do you do? They suffer from things and we take that as being normal. But someone somewhere should have been investigating not just what, but why, and more importantly, what are we going to do about it? And that same statistic, when you talk about Alzheimer's in black women have twice the incidence of Alzheimer's or dementia as white women. Now, that is worthy of a study, wouldn't you think?
I think so.
And we are just getting to the point now where people are asking the questions. And that's why it's important to have diversity in clinical trials. That's why it's important to have diversity in researchers, because it's important to have diversity in the people who fund research. Because people are not going to do a study that they're not going to get money for. And women's health has consistently fallen to the bottom of the list of things. And for perspective, the NIH budget, as of the writing of my book, it's more than that now, but it was $45 billion was NIH uses to fund medical research. Of that $45 billion, less than 11% of that $45 billion, about 4.6 billion, went to conditions that either primarily or exclusively affect women. Women were not included in were not mandated to be included in clinical trials until 1993.
So are you saying that most of the medications that are prescribed are based on studies for men?
For men.
Got it.
Even the medical devices. If you look at pharma now in terms of what their investments are in medications for things, why are women still disproportionately affected with migraines, with cramps, with depression? The list goes on and on of the things that we disproportionately are affected for. And no one is curious as to ask why. Why is that? And I think that the reason it hasn't been addressed is because, one, you, like me, I was unaware of the fact that it was that big of a discrepancy. We're 51% of the population. Why are we still asking questions about or having debates about hormone therapy when it's like, well, then do the damn study. We know enough. Right. But if you still are, if we are arguing about something back and forth for 20 years, then clearly it's not clear.
Clearly.
Then if we're, rather than arguing for 20 years, then prove it. Have someone go forward and say, because this is what we as women deserve. It's what we should demand. And so I want you to do there are two things that I really want to do about this book. One, and I'm again, you're going to get to the end and you're going to go, okay, well, that made sense. It's a long walk around the block, but it comes to hormone therapy. And hormone therapy, which is estrogen and progestin for women who have a uterus, it is estrogen alone if you do not. And for black women, again, have more hysterectomies than white women do. So understand this. Hormone therapy, when started at the time of normal menopause, every society, the North American Menopause Society, ACOG, everybody says the risks are far outweighed by the benefits. From decreasing in the risk, decreases your risk of osteoporosis, decreases your risk of urinary tract infections, painful sex, hot flashes, decreases your risk of cardiovascular disease, the list goes on, hair, skin, All of this is improved with hormone therapy. And to allow that the words that put the death knell on the hormone therapy conversation was really breast cancer. When you said breast cancer, we were like, oh, I don't want that. But let me say that. That study, even when it came out, never said that. There were many flaws in that study in terms of how it was interpreted and how it was overgeneralized to all women. So just understand, hormone therapy is not scary. It shouldn't be, and certainly not for the women who suffer the most. The more symptoms you have, the better an idea that it is. And there are only a few exceptions for who should not, and even that is open for discussion, but women who should not take hormone therapy. But I want you to know that there is no value in suffering. So if you suffer through for 10 years, now will your hot flashes eventually stop? For most people, they do. But there are still women who are having hot flashes and they're 70 years old. And they're like, well, when is this supposed to stop? And I'm like, I have no idea. I have no idea. So if you are bothered, and only you know when it's affecting the quality of your life, please go get treatment. But here's the other, there's always an elephant in the room. And the other elephant in the room is, remember I told you when 22 years ago when we got all the hormones got really branded with the scarlet letter. The problem is that a generation of doctors have grown up thinking the same thing. So women will say, okay, I got it. I know what I'm doing. I think I need some hormones. You'll go in and your doctor will either tell you when you're perimenopausal, oh, it can't be menopause, untrue. Or you're menopausal and they'll just go, what are you going to do about it?
We can't do anything about it.
We can't. Or, hormones are dangerous. Why? Because you have a family history of breast cancer. Family history of breast cancer is not a contraindication to taking hormone therapy. So do not believe that. Your risk is your risk. And I can't tell you, your biggest risk factor for getting breast cancer is living long enough to get it. So that's why I said, I want you to get educated. I want you to be able to say, I am a grown woman. I am capable of looking at the risks and the benefits and making a decision that's right for me. I don't need to be told what I can and cannot have. I need to be able to decide what's right for me. But finding a doctor who will prescribe for you is a problem, and I understand that. I hear it every single day. My doctor said I can't have it.
Dr. Malone, can we do a really specific laser focus on providers? Because
Yes.
I'm looking out into the audience
Yes.
and I see some of our providers in the audience.
Yes.
Can you speak directly to providers
About
about
hormones?
diagnosing, misdiagnosing? Where should they be getting their education? If they are here right now in the room and they're like, oh, I didn't know that. Where should they turn to? Where do they get up to speed, like right now?
There is what's called, it was the North American Menopause Society, now it's the Menopause Society. They have education, they have, a certification test that you can do that, doesn't require you to go away and take a 6-week course. It's just making sure that you are up to date on what the current recommendations are. And if someone is telling you that, then they haven't read anything in 20 years. And let me tell you another problem is because even though most of our care comes, when we talk about hormones, comes from your gynecologist, well, some of us have internal medicine doctors and cardiologists and neurologists and whatever. And if your OBGYN doesn't know what to do, then I guarantee you your internal medicine doctor doesn't know what to do.
Right.
And that's why, and this is, it's a peculiar thing about hormones, because I would hazard to say that in all my years of practicing medicine, I have never had a patient come to me who is placed on a medication by another doctor for whatever their specialty is, and I, as a gynecologist, said, oh, I don't think you should take that. Never. But internists and cardiologists and people who don't know are quick to say, oh, no, you shouldn't be on that. And I'm like, what is that about? I've never changed anybody's insulin regimen.
That reminds me sort of the issue we have when we're talking about, for example, preeclampsia and
Yeah.
aspirin, and going
Yeah.
to the pharmacy and you've been prescribed something by your MFM, and you get to the pharmacy and they're like, oh, I'm not going to fill that prescription for you.
That's crazy. Because again, it gets back to this paternalistic notion. And okay, it's a theory, so take it for what it's worth. I like to tell you what I know and I tell you what I think. So this is just what I think. I think that as OBGYN is now a predominantly female subspecialty, doctors outside our field have no problem overriding what we do and what we say. Because really, you know better. Like I said, I don't change people's cardiology, that for their heart medications, but they have absolutely no problem. And to give you an idea, I've been on hormone therapy now for 15 years, and I saw a new internist, and true story. And I went to see her, and she said, "Oh, what medications you're on?" I told her, I said, "Yeah, well, I take hormones and whatever." And she looked at me and she said, "I'm not a fan." And I looked at her and I said, I didn't ask you. Like,
Period.
Why are you telling? Oh, I'm not a fan. I'm like, well, this isn't a football game either, by the way. But this is what I'm saying about you having to be a good advocate for yourself. And I'll tell you my pivot when I left private practice, and it'll be 4 years this December. When I was trying to decide, and I didn't have any of this in mind. Meanwhile, I wasn't going to write a book. I wasn't going to do any of this. And I ended up being the chief medical advisor for Alloy Women's Health. And we have a very specific mission. And the mission is to make sure that women who need and want hormone therapy they get the education about it, they get the access, and you have trained medical providers on the other end who will prescribe for you. So I say, in an ideal world, sure, go talk to your expertly trained doctor who will individualize treatment for you, and you will go get the treatment you need. That's not real life. And so that's why Alloy Women's Health exists. And then my job is to make sure that we have treatment protocols that will exclude people who shouldn't be on it and not exclude people who really should be and can take. And that's sort of the mission. So I want you to not be discouraged, because if you walk away from this and you go, yeah, I need that, I want that, and you talk to your doctor and your doctor says no, you go, thank you for that. Then we have to realize that there is this whole changing medical environment that we're in is going to require that we approach it differently. And doctors are very resistant to change. We don't like technology. People are still complaining about having an electronic medical record. I'm like, oh, give it a break. We're not writing on charts anymore, But that's why I said we have to understand that sometimes technology is your friend. It's going to help you. It will allow the expertise that I have in my 30 years of practice to train other doctors and to allow them to be able to prescribe for you, because I can leverage that expertise over hundreds, over thousands, in a way that I could never do one-on-one in the office. It's just not enough of us to do it. So I say, don't be afraid to embrace technology. AI is here. It is not going away. It is going to be a very, very much an integral part.
It's a good writer
of how, it is an excellent writer, by the way. But this is how we're going to have to just embrace it, know it. And even though the hormone therapy is sort of new to this digital health platform, it's been around. I mean, men have been getting, you can call up anybody now and get Viagra. It's like, sure, you want it, take it.
Do we have enough time to talk about male birth control finally? You just have to sit and get a... Okay, that's a whole other
argument. I'm like, I don't know. I think I'm going to get that. I'm not sure.
Okay, Dr. Malone.
Yes.
It's 7:08,
okay.
And I know
she's such a stickler for
time.
I
Listen, Mother Desi taught me I have to look, and I know that I want to be respectful of time. we are just so happy to see all these beautiful faces, but I know that folks also have questions.
Yes.
And we want to provide time. And so, where's Orlando? Oh, okay. Orlando raised his hand earlier to show where the microphone was. Allison, if you could please, Allison and Lucine, if you could help facilitate questions, please. If so, don't be shy, because I know that folks came up earlier and said, can we ask this? Can we ask this? If you have a question, I would like to invite you to just queue up right here in the aisle. We're going to ask you to keep your comment or your question very brief. And Dr. Sharon, I am going to ask you to keep your response
brief. I don't know how to do that. Don't you? You've learned. I told her. I said, "Ooh, we're not getting all those questions."
Yes, I am going to ask you to keep your response to maybe 2 minutes. Is that reasonable?
I'll try to be as succinct.
Because I think City Council gives 3 minutes.
Okay.
But we're
Okay. I'm gonna be
two.
very,
So
I'm gonna be very
question
brief.
and then response, and then again, don't be shy. It's not often that we have a superstar like Dr. Sharon Malone that comes all the way from DC to spend an entire day and evening with us. So this is really your opportunity to stand up and ask your question. Please don't be shy, because I guarantee if you have the question, somebody else in the audience has the same question. And I'm going to just give it 5 seconds, because I don't understand why I don't have anybody else standing up. Tanisha's telling me to do something.
You better stand up, or she's going to ask me another question. I'm going to be here for another half an hour.
You have a question? No, I have a
answer.
question. Oh, I didn't forget.
Okay. Okay.
Okay, so we have a line. So
Yes.
go ahead.
Okay.
Introduce yourself and then ask your question, please.
Okay, well, my name is Veronica Illick-Stone, and I am so happy to have you here. And my question is, why do you keep calling it hormone therapy instead of hormone replacement therapy?
You know what? You know how it is where things change over time. It's the same thing, but it has, and again, I won't bore you with this, but what we were trained to call it was hormone replacement therapy. Now, somebody was offended by replacement. I'm like, I don't know why. So then it's hormone therapy, and then it's also menopausal hormone therapy. It's all the same thing. It's just different names. It's still estrogen and progestin if you have a uterus, estrogen alone if you've had a hysterectomy. It's nothing new. It's the same.
Well, I'm here to tell you I'm a big fan.
Thank you for that explanation. Thank you.
Dr. Malone, I'm Pamela Fobbs. Would you address the issue, I believe it was mentioned in the WHI study regarding Premarin and Provera, because some women are still getting that. And in my reality, I was told that it will kill you.
Oh, it makes me so sad. Well, that study, it was started in the 1990s. It was the largest, most expensive, and only study that had ever been done on menopausal women. There's not been anyone. It was a $1 billion study, 40 centers across the country. And here's the problem with it. They used one medication. It was Premarin and Provera, and the Premarin is just, it was the first estrogen that was approved. They only looked at one dose, and the question that they were trying to answer was just one question: does it or does it not decrease the risk of cardiovascular disease? And because it only looked at one medication, we can't say anything about different doses. We can't say anything about the different types. We have different estrogens and different progestins that we use now. But even in the worst case scenario, the same study with the Prem-Pro or Premarin and Provera, which gave us all the negative things that we think about hormones, increase in risk of breast cancer. Let me put it in perspective for you. Even in the worst case scenario, the number of women who were in the study who took estrogen and progestin, the Prem-Pro, the incidence of breast cancer in that group of women was 38 per 10,000 women per year would be diagnosed with breast cancer. Okay, well, against what risk? what's the baseline? Women who didn't take the Primpro, the incidence of breast cancer was 30 per 10,000 per year. So an additional 8 per 10,000, or less than 1 in 1,000 additional cases of breast cancer per year, which was that 26%. See, this is what you can do with percentages. 26% sounds like a lot, but if I told you it's less than 1 in 1,000 additional cases of breast cancer per year, that doesn't sound nearly as scary, right? But here's the kicker that they didn't tell you, and that the incidence, the mortality rate, or the number of the women who died who were diagnosed with breast cancer on the Primpro, the same, whether you took Primpro or whether you took nothing. No increase in the risk of dying from breast cancer. So 1 in 1,000 additional cases per year, no difference in the outcome, whether you took it or not. And that's the worst case scenario. And we now use different estrogens, we use different progestins, and that it is probably even far south of that as to whether or not there's a case. But here's the other part of that study that never got reported, because that one got a big, giant press conference that said, oh my God, breast cancer, 26%, everybody they flushed their hormones down the toilet. But the women who took estrogen only, because they've had a uterus, the incidence of breast cancer, and now we have 20 years of look back on that data, it's not just then, 20 years of look back, the incidence of breast cancer is 23% less in women who took estrogen only. And the incidence of dying from breast cancer, if you were on estrogen, is 40% lower than if you took nothing.
40%.
Now, where is that press conference? Did anybody say anything about
We're
that?
doing it right now.
But see, this is what I'm saying about how you can you can work with statistics. You have to know when someone tells you, buy my Lucky Charm and you're going to increase your risk of winning the lottery by 100%, and you're like, ooh, sign me up, I'll take it. Well, it went from 1 in a billion to 2 in a billion. You're still not going to win the lottery, So that's how, when you read critically and you see these numbers, just kind of take a minute and say, okay, but what's the baseline? 26% of what? And so that's the worst case. And if that's the worst case, even some of the good things that we've learned about hormones really came from that study. But we don't put it in the proper context. And
Dr.
so,
Sharon, can
yes.
I ask Ms. Pam to follow up with you afterwards so we can get to
yes,
more questions?
yes, okay, get to a question, okay. I know,
Okay.
I can go on, I'm sorry. You see, it gets me
Thank
going
you, Dr.
about
Sharon.
this.
Ms.
Okay.
Pam, follow up if you have additional questions.
Hi, Dr. Maloney. My name is Sarah. I'm a second-year medical student here in Clovis, and I just want to thank you for clarifying all those things, especially with the medications, because we just finished that block actually a few weeks ago. I just wanted to ask, as a medical student, as a future doctor, how should we continue to stay educated on menopause besides coming to talks like this, especially with the changing healthcare landscape in the future?
It should be part of the medical curriculum. And I think for 22 years it's really been neglected. And I think they've done a study about it, and they were in internal medicine residents and OBGYN residents, it's somewhere less than 20% of them have really had more than, a cursory treatment of menopause. And let me say why that is so important, is that we spend in OBGYN a lot of time talking about how not to get pregnant, how to treat sexually transmitted infections, how to get a good pregnancy. And these are important things. But let me just say this. Women are going to spend at least a 30% or even 50% of their lives in their postmenopausal years. And we can't just drop off the edge and say, well, you don't need to know anything about that. Let your cardiologist and your internist take care of it. Because that's part of the prevention and the things that we should be discussing with younger women before. So there is really a lot of conversation now about getting more in the medical school curriculum and more in the residency training. So we are correcting that deficit that's happened for the past 22 years.
Awesome, thank you. Yeah, I think we only got maybe 2 hours, kind
Yeah.
of, if you want to combine all the talks about just estrogen and progesterone. So it's
Yeah.
really helpful
So
to
what's
hear
your
this today.
plan?
Come to more talks like this.
No,
You
what
know-
I wanted to hear is, my plan is, now that I have this information, I'm going to go back and I'm going to write a letter to my dean. I'm going to look up curriculum. I am going to say, this is what needs to be incorporated.
Yep.
This is not enough hours. This is how many hours we need.
Right.
Yes, I will do that immediately.
You know what? And,
I will
and-
CC
That's
you,
what I
Shantae.
wanted to hear.
because this is how we have to look at women's health, is that it is a continuum. You know, we're just not one little isolated thing, one after the other. And so many of the drivers of the healthcare disparities, be it maternal mortality, you know, the cancer, cardiovascular, menopause, all of our outcomes, the drivers are the same. And we have to understand that we can't just pick and choose the things that are important, particularly for something that women are gonna spend 30 or 40 years of their lives in.
That's it. Thank you so much.
Thank you.
Thank you.
Should I pull it down? Oh, I'm just gonna take it off. Okay,
That's
thank you.
okay.
Good evening, ladies and Dr. Malone. I'm here advocating for myself.
Yay.
My name is Joy Graves, and I was diagnosed with endometrial sarcoma almost 2 years ago. And when you're talking about the hormone therapy, I wanted to be put on something like that. And I didn't really know how to advocate that, as now hearing what you're discussing, and I'm rethinking things, and I want to go back to my oncologist and the female doctor, but and advocate that, because if you're saying that I have an illness that's terminal, and so I want to be put on something, if I'm going to live the rest of my life however I choose to live it, shouldn't I be able to, the hormone therapy, the estrogen, would help me be more happy during this time versus just be miserable all the way around?
That would be your choice, yes.
Yes.
Because uterine sarcoma is not an estrogen-dependent cancer.
Okay.
The conversation might be different if it were endometrial cancer or uterine cancer of the lining of the uterus. So that's why I said all cancers are not the same, all contraindications are not the same. But at the end of the day, it gets back to what I'm saying. It is about informed consent. And you get to decide the quality of your life is important to you.
Yes.
And if you are having hot flashes and you're miserable and you can't sleep and you can't have sex and you're having urinary tract infections, you might decide, you know what, let's fix this. And I think that bar none, every woman, regardless of what your diagnosis is, can take vaginal estrogen. You know,
Okay.
and vaginal estrogen will help the urinary and vaginal symptoms and vaginal dryness. It's not going to deal with hot flashes. But now, and here's, you know, good news, bad news. Now, if hot flashes are the issue, there are non-hormonal medications that you can use for hot flashes. There is a new one that's called the neurokinin receptors. There's one. But the problem is that those medications are newer. They're more expensive. And we really don't have long-term data on it. We have, you know, again, 80 years of data on hormones. So, but ultimately, it's your decision.
And they don't give you that option. They don't
I
sit
know they don't.
and talk with you about that.
I
The
know
first
they
thing
don't.
my
I know they
oncologist
don't.
said was, you can't do
know.
any estrogen. You can't.
I know.
But yet, I'm on an Keytruda for the type of cancer that I'm going through.
Yeah.
And the side effects are just the same as going through menopause.
Right. And you know what I would say to you about this, because I'm not trying to give individual medical advice, so just understand this. But what I would say is that if a doctor says no, make sure that they understand to your like why. Don't just say no because I said no.
Yes.
Have them give you the data, and a lot of times they don't have it.
They don't. No,
They don't have it. They're just saying, well, no, why? Because it just seems like, you know, and if they can't prove that that there is a benefit in terms of your ultimate outcome, then the decision should be yours.
Thank you.
Okay.
Thank you. So we have time for
Mine is quick,
a couple more.
real quick.
Couple more.
Dr. Malone.
Yes,
Good
ma'am.
evening, and thank you for being here. My name is Phyllis Phillips. My real quick question is, when does that window of opportunity close? I heard you mention you want to start it early. I've ridden out the hot flashes. We done. But I'd like to sleep at night, and I suspect that that's one of those postmenopausal changes. Is it too late for me after 15 years to start?
And again, here's where I would suggest that you do. If you look in my book and you look at all the symptoms of menopause, and then what the things are that you're at risk for. Because the decision about when to start, what we do know is that hormones, you get the most benefit if you start within 10 years of your last menstrual period or before age 60. And it doesn't have to be both and. You know, you might have had
either or.
You know, no, but you might have had your last period at 55, and if you're 62, well, you're still within the 10 years. But this is what I'm saying to you again. It gets back to, this is where there's some individual discussions, because whether or not you want to start outside that window depends upon your personal health risk factors. For cardiovascular disease, do you have other issues that might be, would preclude you taking hormones? And if you say, I'm in great shape, I have my heart's good, everything else is good, then what you get to do is that you get to weigh your risks and benefits. Because when I say before 60 or within 10 years, that's general population. That does not apply to any specific woman, and you need to have that conversation. So we never say never in this business, and I never, you know, and we don't always say always. It depends, because by the same token, if you're 52 years old and you're like, I'm great, I got no hot flashes, I don't have any of those symptoms, and I'm not at risk for osteoporosis, and you say, should I take hormones? And I'm like, I don't know, should you? Because I'm not sure that the benefits would be there for you. So that's when you start getting outside the guidelines, then you deserve a personal conversation about your risks, the benefits, and your treatment goals. You see what I mean? Because quality of life is important. And I think that we give short shrift to women's quality of life. And I think that that's not something, and I go back to this example a lot because we talk about Viagra. There's no overarching societal good for Viagra. It's a quality of life drug. You know,
Wasn't it developed anyways for some?
yeah,
it was
nature
developed
doesn't
for-
care, you know, whether or not, but you do. And so men can look at a Viagra prescription and say, wow, it says I might have an erection lasting for more than 4 hours. It might damage my penis permanently. I might go blind. I might pass out. I might have a heart attack or a stroke. And they're like, I'll take it.
Thank you.
Thank you. Next.
Good evening, I'm Savannah. I have a quick question regarding the beginning of the conversation. So you told us that sometimes women might start experiencing symptoms of menopause in their late 30s, early 40s. What happens if they happen to be on birth control or, for example, an IUD, where that happens to take place for 5 to 10 years? Do they still experience those symptoms of menopause, or does that, when they decide to take that out, do all those symptoms come crashing all at once?
I'll give you a good example, because that's an excellent question. If I said the average age of menopause is 51, well, if you are menopausal at 45, let's just say, you don't know, but you're going to be menopausal at 45, that means your symptoms may start at 35. And there are about 1% of women will be menopausal before the age of 40. And what we didn't talk about, there are other ways to be menopausal. You might have had your ovaries out. You might have had chemotherapy. You might have had radiation, other things that will limit the lifespan of your ovaries. If you are taking birth control pills, you will generally not experience the signs of menopause or perimenopause, because birth control pills are, guess what? Estrogen and progestin. So you are taking the medications that we sometimes use for perimenopausal women. It's just more estrogen and progestin because remember, it's got another job to do. It's not only taking care of symptoms, it's also preventing pregnancy. So, but similar concept, you wouldn't know if you were taking birth control pills when menopause will happen. You generally speaking aren't symptomatic unless you take a whole week off. You know, if you're taking a 21-day cycle and a week off, you might be symptomatic on the week off. But birth control pills generally not. But if you have an IUD and you're not getting your period and you don't know where you are anyway, it will not affect the symptoms. So yes, you can still be symptomatic with a hormonal IUD because it only has progestin, no estrogen in it.
Thank you.
Thank you. Okay, I'm looking at the time, but we have a couple more questions. And
Okay.
then also, the audience really still wants to talk about hair.
Okay,
But
all right.
before we
Okay.
get there, I'm going to
Okay.
cut it down to only a 35-second response. And a 5-second question. So I'm going to invite, I saw Julie, who was queued up, Miss Julie Linksweiler, and then I see Dr. Laporta. Come ask your question. You have 7 seconds, Dr. Laporta.
Okay, but I'd really like to talk about hair. Thank you, Dr. Malone. Question I had was whether the treatments that you're discussing are the same. Like, is there a one-size-fit-all treatment, or does it differ at what age you start, or depending on the individual?
No, it's not a one-size-fits-all, but the concept is it's just estrogen and progestin. So how much, how to take it, whether do I pill or a patch or a spray or whatever, it's still estrogen and progestin. And with the general rule of thumb is you start with a mid-range dose. The younger women are, the closer you are to menopause, usually you'll need higher doses of estrogen because that's what you've been used to. But as you get, older, you can use less. But the right dose is the dose which makes women's symptoms go away. And they will tell you. So there's no absolute dose. It might be different for you than it is for you. But you will know, and there's no value in taking a low dose and only half your symptoms went away. What would be the point of that? Same risk, and you have half the benefit. So take the dose that the patient will tell you when you're like, are you good? Okay, then we're good. Then that's when we stop.
Thank you.
Thank you, Dr. Laporta. Please come up. Miss Julie, please, if you can queue up, please, at the microphone. We still have 30 seconds. Go ahead. No, come. Oh,
Okay.
you guys decide between you.
Okay.
14 years ago, after surviving breast cancer, I was told no estrogen, absolutely, no soy, no nothing. So you're really awakening a question here, like, is it time to go back and ask? But maybe that's one of the diseases.
Everybody can use vaginal estrogen. Let's just say this, because vaginal estrogen is important even if you never take systemic, because the thing that you don't think about, urinary tract infections are the #1 reason for hospitalization in the nursing home population for women. Urinary tract infections. You know what prevents that? Regular maintenance of vaginal estrogen. It's the #2 cause of hospitalizations in community-acquired infections for women, for elderly women. So yes, everybody can have vaginal estrogen, but whether or not to go back and talk about that, I'm going to just punt and say there is an excellent book that discusses this, and it's called Estrogen Matters, and it's by Dr. Avram Blooming, and it's in the list of resources in my book. So that whole discussion, yes, no, when, and Dr. Avram Blooming is an oncologist who has treated breast cancer for 50 years. So a very exhaustive, conversation about that.
Thank you.
Thank you. While our next guest is coming up, I'm going to ask you a yes or no question
Yes.
because it's something that's discussed. Should women be emptying their bladders before engaging in intercourse in
Yes.
terms of UTIs?
Yes.
Why? Why should we do that?
Because just the mechanical effect of intercourse, you have bacteria that are around your urethra, they're in your vagina, and it's very easy for them to be introduced into the bladder. And probably more important, you'll be uncomfortable if you don't empty your bladder before, but it's even more important that you empty your bladder after, because whatever bacteria that gets in there, you need to get it out.
So that's maybe a point for partners, for example, when we're talking in terms of support, being in the moment, right, of being intimate, allowing time to empty the bladder before and after so that we can prevent UTIs. We said this was grown woman talk. Okay.
And I'm just delighted that anyone feels this that urgent. Really? Oh, okay.
Please.
Hi. Sorry, I have to lower this a bit. Thank you so much for being here. First of all, I really appreciate. I'm a big fan of your husband, by the way. Okay, I'm a prosecutor, so I'm telling you, I'm a big fan of you too. So, but what you said about diversity is very important. I had a cerebral aneurysm about 9 years ago, and luckily I was near UC Irvine. So, and my husband did the CPR. So my neurosurgeon, who's Chinese American, told me that in Japan, I used to get migraines. So my doctors here would say, it's just the stress of your job. I said, I don't think so. I love being in court. I love fighting. That's me. They do brain aneurysm, MRIs, but not an MRA. And so my Chinese American neurosurgeon said if they'd done an MRA, they would have seen the tumors growing and growing, and it exploded. That's what happened to Sharon Stone. So she said, unfortunately, a lot of doctors here are male and Caucasian, and they don't look at Asian women who tend to get migraines, all that. So I'm glad you talked about that. So after my aneurysm, then I had an ovary that they thought might be cancerous, so they took it out. So then I started the menopause. And so my current doctor, who is Caucasian and older, because I can't sleep at night, has prescribed gabapentin. So I'm wondering, I see your eyes raising. What is your discussion? But
Didn't
again,
I say I wasn't going to be changing other doctors' prescriptions? But I'm just saying, okay, all right.
So what is your opinion of that?
Let me say this. For the symptoms of menopause, and this is everyone agrees, there is nothing that's more effective than hormone therapy. And again, individually, and again, I don't want to give individual medical advice, but because I don't know the particulars about your particular brain cancer. But just have your doctor look and say, what are the 4 contraindications to it? What are the reasons? Because again, and I will direct you to a book, and it's called The Menopause Brain by Dr. Lisa Mosconi, and she is one of the few people, she's a neuroscientist who's actually looking at the effects of estrogen on the brain. And it appears that estrogen actually has benefits to the brain in terms of blood flow and, brain metabolism. But I would be remiss if I told you that I knew the answer about cerebral aneurysms. I do not.
So thank you so much for that. So we do have Dr. Mosconi's book in our office, if you would like to come check it out. Also, as a community benefit, we're also happy to talk to some of our funders to say we need this book so we can lend it out to the community or give it to the community. And I would like to take this moment to thank Dr. Sharon Malone, because it's 7:37, and she needs to get to book signing. But before we do that, and while we're doing that, I would like to ask Bob Borrow, please, to come up to the stage. And I would like my team to come to the stage to present Bob with a special gift that they picked out for Bob. Bob, what would you like to say about Bob?
He is the most delightful host that I have had in I cannot imagine when.
I don't see any of my team getting up.
A total stranger almost in the middle of the night and go, hey, and then there's a charcuterie board.
It's literally
waiting for
the
you.
middle of the night.
And he was just so lovely, and I have to say he has really made my trip to Fresno really special. So thank you, Bob.
Of course you're embarrassed. So the team is coming up because they want to present something to Bob. But while we're doing that, Dr. Sharon is going to just say a couple words about hair.
About hair? Okay.
Hair. And then we're going to go do the book signing.
Oops. Okay.
You know, the little
Yeah.
conversation
Yeah,
about
yeah.
hair.
Okay. The little
We
conversation
only
about
have
hair.
20 seconds.
Okay, 20 seconds. And I will make it really short. The other thing about menopause and
Gather 'em.
perimenopause that women don't really realize and they're very frustrated by is that once your estrogen levels start to fall, there is this imbalance in your hormones that starts in perimenopause. And women will complain mightily of what I say, hair loss where you want it and hair growth where you don't. So, you know, you're like, whoa, what is going on here? You got mustaches and, you know. And it is because of that imbalance. Usually, women make testosterone as well. And when we are normally ovulating, that estrogen is tempering the effects of testosterone. So when you get to menopause, your estrogen level plummets and it stays gone. But your testosterone level is still kind of there. It's lower than it was, but it's still present. And that's why you tend to get more of these kind of hair things that you don't like, and you're like, what in the world is going on here? Eventually, even that stops, and then hair will just start losing hair. It's like, you know, notice any of you, I'm not asking anybody to raise a hand, but you realize you don't have to shave your legs as often as you used to, you know? So a lot of that, but know that that is also part of perimenopause and into menopause, that you'll get some changes in hair growth.
Thank you.
All right.
So this is the BWPC team. These are the folks behind the scenes. Yes. My microphone. This is everyone that makes it happen. So we have Tanisha, Kata, Allison, Maisha, Bekela, Holly, Marcy, Clarissa, Essence, Juliana, Tanya, Miss V, and you introduced yourself earlier. Say your name. Lucy. Yes. And we have a future OBGYN, Kimsa. We have Nori. We have Tashira. We have Brianna. These are our two doulas also, by the way. We have Brittany, which Brittany is the only Black nurse practitioner, advanced nurse practitioner, certified nurse midwife in Fresno. And then we have Julie. And the team got together to decide what they wanted to present to Bob. Because, you know, Bob has everything. He's the hostess with the mostest. So, who is presenting Bob? And why is that being presented to Bob? Can we please have a standing thank you for the staff, for Dr. Malone, for Bob? We're going to do a quick book signing.
Yeah.
Yes, Bob.
And while they're doing that, I was going to say, Bob's going to have the last word. But for all of you who didn't get books today, please order a book, you know, because this is what I feel passionately about, is that I want the book to be useful, and I want it to be, you know, sort of received in the spirit it was written. And so share it, give it to your friends, and for those of you who didn't get books, there are the signature plates out there, get it, because it is meant to be shared, and I hope that it is helpful. So thank you so much for your attention.
When Shantae was going to call me up and give me a gift, I was so embarrassed. Can you imagine hosting this human being here in your home, having conversations over meals, I'm the winner. The lottery, the lottery.
Thank you, Bob. Okay, that's it.